So the command is, this is a 7 years old boy, Umar. Do the abdominal examination for him. Okay, you can start now.
I will greet the patient and mother, introduce myself, will take the permission for examination. After gel my hands, will talk to patient to build up rapport and put him at ease, will assess his learning capability. Then we'll take the journal look to see if he's alert, sick looking, well looking. We'll see his nutritional status in terms of height, weight, and head circumference.
Okay,
Also,
his weight is, his height is on 2nd centile, weight on 9th centile. He is well communicating and not in distress. Okay, go ahead.
okay. Also see any unusual feature in the face, eyes, ears, nose, mouth, and also see in the surrounding for anything he has brought with him from the home.
No, nothing in the surroundings. You can describe the face and if you want.
Uh, okay, in the end I will describe this one.
Okay.
Now I will start journal examination from hands. We'll see nails. We'll see the nails for leukonychia or koilonychia or digital clubbing. Palms for palmar erythema, paler with the compare with my palms, and we'll see for the tremors, and also see back of the hands for any cannulation scars.
Okay, he has only flat nails and pallor and tinge of jaundice.
Tinge of jaundice. Okay.
Okay.
Okay, then I will feel for the pulse, looking for rate, rhythm, character, and volume.
Okay, 80 beats per minute, regular.
Okay, we'll see on the arms for any bruises, trichiae, or any pigmentation, or any AV fistula.
No, nothing.
So then I will start my examination of the eyes, looking for pallor or any jaundice.
Yes,
Okay.
eyes, there is pallor and jaundice.
In the mouth, I will see for dental hygiene, any oral ulcers, or any deformity in the palate.
Normal mouth.
In the neck, I will see for the visible veins or any scars or visible pulsation.
In the neck, nothing in the neck.
Now I will expose the child after getting permission by keeping his modesty in my mind. Will see for any scars or gynecomastia or spider nevi or any long line in the chest.
Okay, no gynecomastia, no scars, no long line. Normal chest.
Now we'll ask the child, we'll start inspection of the abdomen from the three sides and from the foot end of the bed for an shape of the abdomen, for any surgical scars or any visible veins or any striae, caput medusa, hyperpigmentation or swellings anywhere.
No, only full. You can see there is some fullness in the right hypochondriac area. That's it. By your view, you can see some fullness. No, no other
Where it is?
right hypochondriac.
Right, hypochondria. Okay. After that, we'll start palpation. After asking for any pain to the child, we'll do superficial palpation starting from the left iliac fossa in the S-shaped manner, and at the same time looking for the child if is feeling pain, anything.
No pain.
Comfortable.
He's
Then I will start.
comfortable.
Okay. Then I will start deep palpation for the liver, starting from the right iliac fossa coming upward, and ask the child to take deep breath. In expiration, will move deep. Is there any
Yes,
hepatomegaly?
yes, you can palpate liver, which is 4 centimeters below the costal margin.
Okay, then we'll do the percussion to check for the total upper border of the liver and the total span of the liver. And
Can you
also,
tell how you do the percussion?
I will do the percussion. Uh, can start from the chest and coming to downward, or even can start from the same time to the upward, where is I feeling the resonant.
Okay.
Okay.
When the total liver span is 12 centimeters. Next.
Okay. Then I will check for the left lobe of the liver also.
Not enlarged. Means
Okay, then
slightly, the 4 centimeters is like slant line. It is clear you can.
okay.
Okay.
Okay, then I will do the palpation for the spleen, starting from the right iliac fossa, obliquely going to the left sternal border.
You could not feel the spleen. Next.
Okay, then I will do the check the uh, shifting dullness for any ascites.
No shifting dullness. Then next.
Then we'll check for we'll do the auscultation for the bowel sounds and the bruit for the liver and the renal bruit.
Bowel sounds present, no liver or no renal bruit. Next.
Then we'll check for the pedal edema. And now I will ask the child to sit and start inspection of back from for scars, swellings, palpate for the spine and renal angle, and will also do the percussion for the renal angle and auscultation for the renal bruit on the back.
No findings in the back. Time finish. So do
In
enough.
order to complete my examination, we'll check for the any lymph nodes, hernial orifices, and genital examination and anal examination, and would like to plot his height and weight on the appropriate growth chart, and we'll check for the vitals.
Hmm.
So,
So with
uh,
these findings, what is your differential diagnosis?
uh, first I will present, or
Okay, present. Okay, present.
what was the name? 7 years old.
Umar.
You did not tell. Omar. Okay. 7 years. Today, I thank you for asking the examination. Today, I examined Omar. Omar, who is 7 years old. He's uh, he's paler, and he's having uh, hepatomegaly. That is total span is 14 centimeter, 4 centimeter below the left costal margin, and the tinge of jaundice.
Okay.
And there is no stigmata of chronic liver disease.
Hmm.
Okay.
So with these
And,
findings, what is your
and with these finding, I am thinking of this possibility of uh, and this storage disorder.
there is jaundice and there is hepatomegaly and no splenomegaly, but there is jaundice.
There is jaundice. Okay,
Yeah.
you told me in the eyes only pallor.
No, I told eyes, pallor and jaundice. Hand also there is
Uh-huh.
tinge of jaundice.
Okay, then jaundice is there, hepatomegaly is there. This
7 years
can be,
old.
and this is also a ethnicity. I can see this is possibility of sickle cell disease.
Yeah. So chronic hemolytic anemia.
Chronic hemolytic anemia, most
Most
probably is
likely
sickle cell anemia. Sickle cell anemia.
anemia. Your other differentials?
Other differential, I can think of this hereditary spherocytosis also, but there should be a hepatosplenomegaly. Okay, and hepatomegaly will be not too much, and splenomegaly should be there. I can think of thalassemia. Again, this is going in the not against the thalassemia, as there is no splenomegaly and there are no features of on the face for the thalassemia. And storage disorder, I can think of storage disorder, but there is jaundice also,
Okay.
so that will be less likely
So,
also.
so if this is the case of sickle cell anemia, how do you want to manage this case?
First of all, I have done examination. I will take the proper history, and will take the after taking the history, I will do the vitals for the child, and will do some will run some tests like complete blood count with peripheral smear. I will look for the hemoglobin levels, and in the peripheral smear I will look for the uh, uh, for poikilocytosis there can be, and sickle cells or target cells can be there, and we would like to do the electrophoresis for the child. and that will be, I would like to see for the HPS, that
Oh,
can be 20%.
mm. Okay, this is the investigations. Management, how do you want to do?
Management is, at the moment, as there is child is not in crisis or looking phase. So at the moment, just needs to tell the diagnosis to the child, to the parents, and educate the parents about the disease and about its consequences. And there are certain complications which can encountered in the sickle cell anemia, like there can be aplastic crisis or sequestration crisis, and there can be like acute syndrome, or sometimes these child may have hemolytic crisis and the stroke. So all these needs to be discussed with the parents, and give advice for not to go high hiking, and should um, uh, and if the child is having any time fever, should come to the hospital, or any kind of infection should consult to the doctor. And for the uh, proper treatment is like folic acid we can give, and we can give the hydroxyurea to convert of hemoglobin A into the hemoglobin F. That will help. And the proper curable is bone marrow transplantation. And I will give for, this is a genetic disease, autosomal recessive, so genetic counseling is also important. And immunization for the, because in the sickle cell anemia there is autosplenectomy. So I would like to see his previous notes, if he has been given any immunization or not.
Okay. So if what is the multidisciplinary team you will involve here?
Yeah, multidisciplinary team, like a multidisciplinary team in my consultant and hematologist. I would like to involve the geneticist. I would like to involve also the immunologist, and would like to involve also orthopedic surgeon, and the paramedical physiotherapy, occupational therapist, and uh,
Okay.
community pediatrician to join all these. But first of all, I have to see the previous notes, if there are any complications has been encountered in this child.
Okay. So
And
HB,
school nurse also. Sorry.
okay. Hydroxyurea, how it will help these children? How it will
Yeah, this is a hydroxyurea help to conversion of the hemoglobin A into the hemoglobin F. That will increase the red blood cells hydration also, and increase the nitric oxide. So hemoglobin F will be increased finally. So that will help for not sickling of the RBCs.
prevention of, it will prevent vaso-occlusive crisis,
Yeah, vaso-occlusive crisis.
because the
Yes.
sickle the sickle hemoglobin will get reduced by
Yeah,
increase of HbF and decrease of HbS. What
HBS.
is the target level of HbS usually to maintain?
Target level 9 to 10 is the target level, should be there.
Okay. In mark, it's given below 30%. I don't know about the
That
recent.
that that one is, I think, to prevent the stroke.
Even here, even with
Yeah,
hydroxyurea,
you are asking for the hemoglobin F, huh?
even in
Sorry, hemoglobin A. Yeah, that one is below the 30%, according to the
in these
hemoglobin F.
patients, the hemoglobin A, we call it as hemoglobin S, because there is
Yeah, sickling.
because there is defect here. The hemoglobin A becomes hemoglobin S.
Yes, yes,
This
yes.
hemoglobin S target is less than 30%. It should be
Yeah,
used
that is less than 30%
to
to
prevent
prevent the,
complications.
yeah, complications, of, especially for the stroke.
Yeah. And the definitive management, as you said, allogenic bone marrow transplantation, both for
Yeah.
thalassemia, also for this also. Yeah. So if a child is coming with vaso-occlusive crisis, at that time, how do you manage the child?
For the vaso-occlusive crisis, first of all, I would like to admit the child and
Okay.
yeah, warm the child and give the proper hydration. If there is acute infection is there, would like to give the antibiotic, or there can be given penicillin prophylaxis also, and folic acid. And for the pain, can be used morphine.
Okay. But important thing you forget to mention oxygen. Very
Oxygen,
important.
yeah,
Yeah.
oxygen. Yeah,
So immediately what admission is very important, but immediate management before admission in the ER is the oxygen, warmth,
yeah,
and hydration and
yeah,
anal
warm hydration,
and IV
warm
antibiotics.
hydration, oxygenation, and antibiotics.
Antibiotics and analgesia, all. And then you will
Analgesia,
proceed
yes,
for admission.
yes, yes.
Um, this and for asplenia, I think you already told you will check for the
Yeah,
immunization
for asplenia, I have to check for the immunization status of the child in the
and
previous
IV
notes,
antibiotics.
and we can give this pneumococcal for the conjugated and unconjugated, H influenza and meningococcal, and the penicillin prophylaxis for the long life.
Yeah.
Yes.
So about the exchange transfusion, for which cases you will consider exchange?
A change transfusions are we are considering in the if the child is having any cardiovascular accident, or if the child is encountered with acute chest syndrome or priapism.
Yeah. Cardiovascular or cerebrovascular?
Yeah, cerebrovascular.
Yeah.
Cerebrovascular.
Okay. So acute chest syndrome, stroke, and even in priapism, you can
Yeah.
consider exchange transfusion.
And for the blood transfusion, that will be blood transfusion, not exchange. That is sequestration crisis or aplastic crisis. In the aplastic crisis, mostly we'll have to check for B9 parvovirus B19 also.
Yeah. So in aplastic crisis and sequestration crisis, you will consider for top-up
Blood
blood
transfusions.
transfusions. Okay.
So they may have, if we want to complete this one, they may have complications like hemolytic crisis. There can be like vaso-occlusive crisis. In the vaso-occlusive crisis, there can be painful crisis in the like abdominal pain or fingers, which we have seen, I think before. That is dactylitis. And there can be a crisis in the spleen, that is we call sequestration crisis, that will functional acyclemia can be there. These all are with the vaso-occlusive crisis. There can be acute chest syndrome, stroke, priapism,
Doctor,
avas-
yeah,
avascular necrosis of femoral head, and there can be leg ulcers. In the chronic hemolysis, there will be chronic anemia and the jaundice. And the acute hemolytic crisis, that can be aplastic crisis, or there can be splenic sequestration crisis. Aplastic crisis will be due to parvovirus B19, and or that leads to the bone marrow failure. And for the sequestration crisis, that is due to the blood pools in the spleen that causes circulatory collapse. And for that, as already mentioned, that blood transfusion is necessary to give. So there are so many crises: chronic hemolysis, acute hemolysis crisis, vaso-occlusive crisis. All these are coming, especially these three things. So you should mention about the acute chest syndrome, stroke, priapism, avascular necrosis of femoral head. Sometimes they may have problems in the kidneys, that is papillary necrosis. Sometimes they may have problems in the atrophy of the eyes. So all these, so in the long term complication, there can be retinopathy. There may have problems with the renal impairment. They may have problems with the leg ulcers. So this is all points for the if the child is if the history is coming. So they may have problems with the cardiomegaly. They may have, that is due to the hemolytic crisis. Heart failure can lead to that. So causes of the actually causes of the abdominal pain are not only for this sequestration or this vaso-occlusive. There can be some gallstones can be there, or sometimes the child may have lower lobe pneumonia, and sometimes they may have even hepatopathy due to sickling of the RBCs. So these are the causes of the abdominal pain. They may ask you what are the causes of the abdominal pain. Apart from sickle crisis and sequestration crisis, there may be gallstones, lower lobe pneumonia, and sickle hepatopathy. So that Dr. Noor, you told that we should do annual screening to for check the hemoglobin level to decrease the risk of the stroke in sickle cell
So
disease.
they are doing all this transcranial Doppler in cases of
Yeah,
stroke cases annually. And their target is to keep the HBS below 30%.
yes. And what advice you would like to give the parents that will be avoid high hiking or this one what we call high altitudes to avoid maintain his proper hydration and also to avoid cold swimmings that can lead to the crisis. So also we will have to involve the school nurse involvement should be there, and education planning for the child, and the parents also should tell the child about this uh, high altitude, maintain good hydration and cold swimming.
So by the transcranial ultrasounds, by the transcranial Doppler scans, they will get to know the level of HBS or what?
No. This one is transcutaneous scan is to check for their uh,
It's the velocity across
yeah,
the
last yeah
cerebral
yeah
blood
Dr.
vessel.
Yes, they are checking in the blood vessel actually. This is not for the
Yeah.
HBS.
It's a Doppler ultrasound to check for the velocity across the
It is
cerebral vessel.
it is
If it
just
is
like
more than 120, there
yeah,
is
yeah.
indication for. And when do you start the transcranial ultrasound annually? Go ahead.
Dr. Faiza, we cannot listen. Your voice is yeah.
When do you start for monitoring for transcranial ultrasound?
The age.
After no, when any child who has stroke will be
Yeah.
monitored. Any child who has stroke, every year they will do this.
If the child is has stroke, for that every and particular age, I don't remember. Maybe 5 or 7 years. I don't remember.
Dr. Noor's answer was correct. Once you have a stroke, you do it annually.
Oh,
Otherwise, no need.
no need. Okay. So this one is HBS. What is our target value, Dr. Faiza, for the in the sickle cell, where we are not giving any transfusion or something like this?
I have no idea. I haven't read it. I mean, you can ask Dr. Noor
Somebody,
can answer.
I also did not read from anywhere, but somebody told me the target value is 9. HB 9 should be at least should be there. But I don't know. That is
HBS 9%, you mean?
9. Total HB should be 9.
Yeah.
But I don't. I'm
Hemoglobin.
not sure about that. I'm not sure
It's
about
not
that.
written in mark. I can't remember now.
In yesterday we read for thalassemia as 9.5, but let's see here if he has given anything.
Yeah, in thalassemia 9.5 or 10, especially they are saying, but I don't know here. Is there any value? But in some meeting, I think I have listened this, but I'm not sure that.
Okay. So here for the differential, you can give other causes of hemolytic anemia. And whenever the child is in pain, you have to always in a sickle cell anemia patient, take it as it's an acute painful crisis or acute sickling crisis unless ruled out otherwise. Okay. So assess all patients with sickle cell disease who present with acute pain to determine whether the pain is being caused by acute painful sickle episode or whether an alternative diagnosis is possible. And alternative diagnosis, you will think only if the pain is atypical. Next, investigations is very important. So FB. So full blood count and blood film. The hemoglobin level is in the range of 6 to 8 grams per deciliter with high reticulocyte count of 10 to 20%. So usually when you do the blood film, you will see a low hemoglobin from 6 to 8 grams may be present. And also you will have high reticulocyte counts, 10 to 20%. And blood films will show sickled erythrocytes and features of hyposplenism. Okay, what are the features of hyposplenism in blood film? What you see usually? Damaged red cells, right?
Hyposplenism,
Holy jolly
I don't
bodies.
think
Is
so.
it called like that? Holy jolly bodies?
Yeah, holy jolly bodies we are seeing for that.
Okay, yes, Howell Jolly body.
Yeah, or we called it Haynes bodies. Yes.
Yeah. So that means whenever, for suppose in a child more than 5 years, you can see whoever has functional asplenia in these patients, they have hyposplenism because the spleen is not functioning. So you can see the features of hyposplenism like Howell-Jolly bodies and also sickled erythrocytes you can see. So important, you have to tell in the exam, FBC, there will be anemia. And in blood film, you can see sickled erythrocytes and also features of hyposplenism like Howell-Jolly bodies, okay? And reticulocyte counts will be raised.
Mhm.
Sickling of red cells on blood film with 2% sodium metabisulfite. You can also put this 2% sodium metabisulfite and check for sickling of red cells on blood film. This can also be done. If suppose if you did not get a sickle cell on the blood film and you are suspecting the disease, you can confirm like this.
Okay.
Okay. Next is the, I don't know whether we have to tell this in exam or not. I'll just read. Sickle solubility test. A mixture of HBS in a reducing solution such as sodium dithionate gives a turbid appearance because of precipitation of HBS, whereas normal hemoglobin gives clear solution. We can know this only. I don't know. We shouldn't tell too many things and get into problems because there it will be only 3 minutes discussion, right? So better to go with important things, but know that there is a solution that is sodium dithionate. If you mix, if there is HBS, you will get an turbid appearance, but it will be clear if it is just HBA. No only, no need to mention unless asked. Then hemoglobin analysis, that is electrophoresis, is always needed to confirm the diagnosis. Both yesterday we read in thalassemia also, your confirmatory diagnosis is by electrophoresis. Okay, so what you will see in the hemoglobin, no HbA. Okay, 80 to 90% HbS you will see, and 20 to 20% HbF. So it will be in sickle cell anemia. Usually in cases of sickle cell anemia with both the genes are defective, you will have 80 to 95% of HbS and 20 to 20% of HbF with absolutely no HbA also, or maybe very little. Then sickle cell trait is diagnosed by finding a positive sickling test together with hemoglobin A and S on electrophoresis. So if both A and S are there, maybe half, you can take it as trait. But in anemia, sickle cell anemia, usually very less or no HbA will be present. Okay, so hemoglobin electrophoresis will give you the diagnosis. Other investigations you can do is the renal function test, liver function test, and lung function test should be performed at diagnosis as the baseline, and routine monitoring. So
we should, in the exam, we should tell all these LFTs, RFTs, even we don't know the status. So for the baseline, we should tell for that.
No,
Yeah?
you will tell everything. You will say, I will do diagnostic labs and I will do supportive labs. In diagnostic labs, you will do hemoglobin electrophoresis In supportive lab, you would like to see the CBC for the status of hemoglobin, for thrombocytopenia or thrombocytosis, LFTs, ultrasound abdomen, X-ray chest, urea creatinine, and electrolytes. This is mandatory, diagnostic and supportive, okay? And depending upon the case, if fever, blood culture, CRP.
Okay. So here, as usual, we have to do the renal function test usually. As Dr. Rohel was telling, it can affect the kidneys also. And there will be hepatomegaly and bilirubin will be raised. So you need liver function tests. And lung function tests, this is extra which you should remember, should be always performed at the baseline, because maybe they are prone to acute chest syndrome and there can be lung infarctions before, right? So there can be some compromise in the lung functions due to previous acute chest syndromes or some infections and loss of the lung tissue. So baseline lung function tests becomes important here, and monitoring the children routinely. Other investigations will depend on any complications. Like if the child has fever, you will go for infection screen, CBC, CRP, blood culture, and the specific cultures like urine if you suspect urine or something. Then abdominal ultrasound, CT scan of the head if subarachnoid hemorrhage is suspected, and also in cases of stroke, and if this subarachnoid hemorrhage is suspected, you can go for CT scan and also abdominal ultrasound. Screening, usually neonatal screening programs can identify children with sickle cell disease before they present with potential fatal sepsis. So neonatal screening will help, as we know that this disease will appear to you only after 3 to 6 months. So neonatal screening will give you an idea that this child has sickle cell disease, and you have to follow up the patient so that they will not present you for the first time with fatal sepsis. So heel prick blood spots are usually collected 3 to 10 days after birth, and hemoglobin is analyzed. This reliably identifies affected babies and allows penicillin to be started by 3 months of age. I think with this heel prick, they are doing hemoglobin electrophoresis for diagnosis, or what?
No,
That is screening.
No.
They are doing screening. So, okay. With the heel prick test, by 3 to 10 days, they will analyze the hemoglobin, and if they are diagnosed positive, by 3 months, they will start penicillin.
I had a question. What type of penicillin they are using? It is penicillin V, or we always get confused?
I think penicillin V they are using.
Yeah, I think so.
Oral penicillin it is.
Because in rheumatic fever, there is benzyl penicillin. Not sure.
In rheumatic fever, they are using this Pencitard, that is benzathine penicillin.
Once in 21 days, you have to give IM. This one here, penicillin V, it is also known as phenoxymethyl penicillin, right?
Yeah, this is V is phenoxymethyl penicillin.
Which can be used orally.
Yes.
So some genetic counseling is very important here. Okay. So policies of antenatal and neonatal screening vary throughout the UK. They are screening even for all pregnant women to know whether the child will have sickle cell or not. If the pregnant woman is positive, they will check the partner as well. Okay. Like all biological fathers are often screening if the pregnant woman is a genetic carrier of sickle cell disease or thalassemia, both. And all newborn babies are offered sickle cell screening as a part of newborn blood spot screening program, usually by when they are 5 days of age.
Yes.
In low prevalence area, the family origin. So in low prevalence area, they will see for the family origin. Okay, questionnaire is used to determine if a person is likely to be a carrier of sickle cell disease and other hemoglobin disorders. So especially suppose if they are ethnic groups like the African based, then they will also do preoperative screening for sickle cell disease. Should be carried out in patients with ethnic groups in which there is significant prevalence of the condition.
Dr. Noor, this in the picture, there was this gum hypertrophy or what? That was overload too much.
Yeah, it was just smiling. I don't know why it was like that, but it was a case of sickle cell anemia in the Google.
Okay, yeah.
So you have to also do the prenatal diagnosis. Suppose if both the parents have or the carriers, okay. Sickle cell disease can also be diagnosed in a fetus through prenatal diagnosis from amniocentesis, chorionic villus sampling, and fetal blood sampling. Anything can be done. Amniocentesis, chorionic villus sampling, and fetal blood sampling. This is they should, before that they will do the genetic counseling. If both the parents are the carriers, they will do the genetic counseling and do this prenatal scanning. So what are the indications to urgent referral to hospital? One is the severe pain not controlled by simple analgesia or even low dose opioids. Then dehydration can caused by severe vomiting and diarrhea. A patient with sickle cell disease with severe and vomiting and diarrhea, dehydration can precipitate acute vaso-occlusive crisis. So you will refer the patient. Severe sepsis, temperature more than 38.5 and more than 38 degree if under 2 years, and also hypothermia, temperature less than 36, and hypotension. Okay. Then acute chest syndrome, symptoms and signs including tachypnea, oxygen saturation more than 5% below steady state. Means usually 93 and above is normal, right? Like 92 and below, you have to send them. Signs of lung consolidation, new neurological symptoms and signs, symptoms of signs of acute fall in hemoglobin, acute enlargement of spleen or liver over 24 hours. This is splenic sequestration. Sudden enlargement of the spleen, particularly in young children. Marked increase in jaundice, hematuria, fulminant priapism lasting more than 2 hours or worsening of recurrent episodes.
Dr. Noor, I just have a comment regarding the acute enlargement of the spleen. That's why it's important we should educate the parents that they should palpate, know how to palpate for the spleen.
Okay.
This should be managed. This should be mentioned in the management part.
Yes, you are right.
Yes.
That is not only mentioned in the mark. Still, they are doing it in UK practice. They are nursing is learning the parents how to palpate.
Yeah, so in the education, along with what you are telling, that you should teach them that they should be careful when they go to high altitude, or they should not take their children to high altitude, right?
Yeah, should not like cold swimmings should be avoided. Should be avoided that in the this high altitudes, or sometimes they are going for this cold areas, hiking. All these should be avoided. And again, this parent should be educated about this palpation of the spleen, and nursing school nurse should be aware of the child is having this condition. And because sometimes schools are for the school excursion management also for that.
Yeah.
And sometimes, yeah, okay.
So if you have to list in the management, just these points has to be listed. Early diagnosis. So for the early diagnosis in any patients, they are doing neonatal blood sampling. Yeah, okay. Yes. Spot test. And also, and if there is ethnicity, if you have doubts, even the prenatal scanning is done, and the parents are also screened for sickle cell anemia. Then early diagnosis is very important. Then penicillin prophylaxis. Once if the baby is diagnosed with this neonatal blood spot test, as early as 3 months, they will start penicillin prophylaxis. This is what we read. Okay. Then blood transfusions. transcranial Doppler imaging, hydroxyurea, and hematopoietic stem cell transplantation can dramatically improve survival and quality of life in patients with sickle cell disease. So this should be your points.
This one is the new, this hematopoietic stem cell transplantation. Okay, good.
So in your point, you have to tell that early diagnosis will help us to prevent the complications, and penicillin prophylaxis can be started as early as 3 months of age, and then blood transfusions wherever needed, and transcranial Doppler imaging to suspect for the stroke and also in patients with stroke. Then hydroxyurea to increase the level of HBS and decrease the level of HBS, and your target will be less than 30%. But I will read if he has given anything more here. And hematopoietic stem cell transplantation. Yesterday also we read about this national hemoglobinopathy cards are available for affected carrier and normal individuals following hemoglobinopathy screening. Whoever they are doing the screening, they are giving the cards to them. They should to carry, means the carriers will have as carrier card and affected will have affected card. It is considered good practice to issue hemoglobinopathy cards to those with a major hemoglobinopathy and also to carriers where a definitive diagnosis can be made. So they are giving these hemoglobinopathy cards to them. And what is the follow-up? It is very important that people with sickle cell disease should be reviewed regularly at specialist center. Non-specialist hospitals should contact the nearest specialist center when treating patients with sickle cell disease. So what
This is,
here?
sorry, Dr. Noor.
Yes. Tell me, Dr. Faiza.
These are the guidelines which you are reading from Mark Betty.
No, this is from patient info. So what is the patient? Okay, patient should be regularly monitored for their growth. As we know, any chronic condition will have effect on the growth, and these children will have anemia and sickling, vaso-occlusive crisis, repeated admissions, acute chest syndrome. All these will have effect on the growth. So they should be monitored for their growth, development, organ function tests. That's why he told in the beginning, lung function test, when you have diagnosed for the first time, you will start with it. So organ function, so that active management may be considered before organ failure develops. So organ